a very, very stimulating morning so far, and we have many more goodies to come. I'm here to introduce Dr. Quentin Van Meter. Van Meter. I don't know him. I know we've never met before, but I do know that my colleague, Alan Williams, who's around somewhere, he's a chair, Alan, are you around here? He's the chair of the Support for the Family Group, and he's one of the real leading lights behind this conference. He went and heard Dr. Van Meter speak at the conference, and he came back so excited. He said, we've got to have him to our own conference. We've simply got to. So I'm really excited to meet you, and very excited to hear, sir, what you have to say. So could we please give a big hand to Dr. Van Meter. Thank you.
Just explain who I am. I'm a pediatric endocrinologist. That is, I take care of children who have endocrine disorders, hormonal imbalances. And so this is naturally the medical side of transgender treatment that is suggested, impinges on pediatric endocrinologists to try to provide these services or to discuss why these services might be at some harm. So what I wanted to do with this particular talk is a little bit of historical background will float in at the beginning. But it's talking about to the families, to the professionals, to the press, anybody that would be interested in listening to scientific truth, about being transparent about what this transgender movement is from the medical treatment side. So I must disclose that I am a clinical researcher for AbbVie Pharmaceuticals. Although I'm a private practice pediatrician, I've always had an interest in clinical research. And AbbVie is a pharmaceutical company that has developed one of the puberty blockers that's often used in suggestive treatments. And I'm on the Speakers Bureau, but I literally stick to the FDA guidelines in terms of recommending the puberty blockers for what they were originally planned to be used for, and that was to block puberty when it happens in very young children, age 3, 4, 5, 6, 7, who enter full-blown puberty at that early age. We intervene with this kind of medication to stop the progression of puberty temporarily until it's of a more appropriate age. So we talked a little bit about terminology. Transgender indicates that a person feels they are trapped in the body of the wrong biologic sex. It was originally called transsexual. Gender identity as a concept was something that Professor John Money from Johns Hopkins, who's a clinical psychologist on the faculty there, he termed this as the identity of the inner sexed self. Previously, the term gender had to do with language. He took that word from the feminine and masculine nouns in French and German language and other classic languages, and applied it to human beings. Before that, if you look in the medical research, the word gender did not exist in speaking of human beings. And today, it's a 50-50 chance that when you fill out an application for a job or a driver's license or any government entity, you need to put in there half the time it'll ask for sex as male and female, half the time it'll ask for gender in place of the word sex, as if the word sex was somehow dirty and inappropriate to use on a form. Money theorized that gender was recognized by the patient at about 18 months of age. And the reason that he chose this, and this again was a theory in his head, there was no basic science for this, was because he was dealing with the patients at Johns Hopkins who had disorders of sexual differentiation or ambiguous genitalia, who presented for evaluation of why that happened, what hormonal imbalances might have been there, and how to raise that child subsequently. Disorders of sexual differentiation was previously called ambiguous genitalia or intersex. It is either an under-virilized XY biologic male or an over-virilized XX biologic female. Both XX and XY cell lines in very few of these patients can coexist in the same individual, and they actually have both gonadal structures in their body, either one ovary, one testis, or a combination in that single gonad. These patients are not transgender. Very interestingly, they are used often to rationalize the concept that gender is innate, not biologic sex, when in truth the majority of these patients have absolutely no problem with gender identity at all. As a matter of fact, the patients that Dr. Money worked with and who he recommended that their genders be changed from their biologic sex and these children be raised that way, the majority of those patients came back later in life and re-chose their biologic sex to match their gender, to match their sex. So this is not something that is a common problem, and the people who have disorders of sexual differentiation staunchly oppose being lumped into the transgender crowd. The triple threat to the launch of the sexual revolution were three individuals: John Money, who had already spoken, from Johns Hopkins. He was a Harvard-trained psychologist. He joined the Hopkins faculty in 1951, and he created what was called the psycho-hormonal group there. He assessed infants with disorders of sexual differentiation and children with early puberty, either due to the pituitary signaling first, or tumors of the ovary or the testicle or the liver that happened to overproduce the hormones of puberty and appeared to be puberty, but actually were not. He also treated a small cadre of adult transsexual patients. Harry Benjamin was a family physician practicing in New York in the summers and the falls. He would, in the heat of the summer, he would go to San Francisco, where he practiced in his family medicine practice there. He was an individual without any mental health training who essentially started with money and the next character, the sexual revolution. He facilitated the sex change of one of the most famous transsexual patients, Christine Jorgensen. And then lastly of this trio was Alfred Kinsey, who of all things was an entomologist. He studied the behavior of the mud wasp. Okay, that was his scientific background. He was at Indiana University in the biology department, and he was asked to sub in as a teacher for the college class on marriage and the family. He had no background in psychology. He was just sort of thrown into position to sub in for this, and he suddenly seized on that idea of talking to college students about human sexuality and marriage. And then very quickly that devolved into his questionnaire about what was normal human sexual behavior. So this man who had no training in biology of humans, who had no training in mental health, became the icon of sexual revolution in his books that he published in the 1950s. Money's legacy at Hopkins was the disastrous outcome of a male twin patient. This was a newborn who was circumcised inappropriately. Well, they botched the circumcision. They burnt off the whole of the penis accidentally during trying to cauterize some bleeding. So Money and his team came in and evaluated this patient and said there's obviously no way that this child can function as a female. So we are going to transition this boy to a girl. So his male twin brother stayed the male in the family, and this child was reared as a female. They did sexual excision of all gonadal structures in infancy, tried to create a somewhat functional vaginal orifice, which never worked, and this child was reared as a girl. He had chronic problems with underlying anxiety and depression, and finally his therapist, who was not John Money, but an independent therapist, suggested to the family that this child needed to know the medical background. And when they divulged to this boy that he was actually born a biologic male, it opened up a whole healing experience for him to some extent. Under the auspices of John Money, this girl was encouraged to play with his brother's genitalia and vice versa by Dr. Money, just because he thought it would be a good idea to allow this child to grow up as a female and feel that that was normal behavior. Money was unequivocally a perverted individual. I don't say that in a sense of I never knew him, I don't know him, I'm just reading about him. He actually was on the faculty at Johns Hopkins when I was a fellow there in endocrinology, and I was exposed directly to an incredible amount of his absolutely hideous sexual education of fellows and medical students at Johns Hopkins at the time. He was a man who we shunned if we possibly could. and we were never really happy with what he tried to teach us about this. We were never comfortable with it. So this case where this boy grew up as a female and then was transitioned back to a male, this young man had some reconstruction of what was left of his phallic stump so that he could have some form of intercourse successfully. And as a young adult male, he took his life. And at that point, all of this came out into the press, and John Money was pretty much defunct at that point in time. His department chair, Professor Paul McHugh, had arrived in the late 1970s and was aware of the transsexual program and its failures in these adults. All of the transsexual patients that were in, adults that were in Money's program never resolved their undercurrent anxiety and depression. They were no better in terms of their mental health after they'd gone through what he promoted. And so that program was shut down, and Money was no longer able to publish his opinions as long as Professor McHugh was on the faculty, because he was the gatekeeper of what could be published underneath the Johns Hopkins promontory, and he would not allow Money to continue that. And as a result, Money program was shut down. Money was sent packing, and that chapter was buried in the basement of Johns Hopkins, hope we thought forever. So the standards for more appropriate management of disorders of sexual differentiation were created primarily because of the confusion between intersex or DSDs and the transgender community. The scientists in the endocrine world made sure that they did not want to have this become a political issue for these patients who had very specific disorders that had very strong standards and careful treatment that was to be beneficial. So none of the undercurrent morbidities, as I said, went away with this intervention, and that program was closed down. His legacy was a disastrous outcome, and as I said, Paul McHugh, the chairman, decided it was time for him to go. Now, Harry Benjamin lived on after he passed away through the Harry Benjamin Society, which was organized by transgender, transsexual activists around the world. It was named after him. It was international, but primarily based in Europe. In the United States, there was no tolerance for this kind of lack of science and sort of social engineering. So it was based mostly in Europe. They gathered transgender persons and those who promoted medical and surgical treatment together under the umbrella of the Harry Benjamin Society, and they changed the name then to the World Professional Association of Transgender Health. That sounds really scientifically based, would you agree? These are professionals, these are certified individuals, they're based on science, and they're making recommendations. Membership in the society requires no degree, no training. You just pay your dues, and you get a letter that says you're a member. That is the depth of the background of the majority of the WPATH people. The Kinsey Institute, which is how Kinsey's influence has lived on, they evaluated human sexual behaviors by his surveys of adult men and women. Interestingly, many of his male subjects were incarcerated. So if you think about the worldview of sex of a male prisoner and ask them questions about what they do, and then say that's the spectrum of normal behavior, you might not be getting a representative population of adult males. Many of the women were prostitutes. He created the impression that the previously deviant behaviors were now part of the normal spectrum, and he published his books, and they were widely accepted. Major funding foundations in the United States, the Ford Foundation, supported his works, and he got all of this information sort of built into case law to set standards of care and behavior. He also, on the side, studied sexual arousal of infants and young children, and there is in his book on male sexuality, a table number 34, which describes how many times he was able to masturbate an infant to orgasm. If you think about that, it's openly published. This is not secret. This is not hidden somewhere. It's in the book, and yet it was overlooked. This is clearly perverted behavior. So the U.S. landscape for transgender treatment from 1980 to 2006 Hopkins was a laughingstock of the endocrine academic divisions because John Money had launched onto this transgender treatment center and created that. And we were the folly of everybody who was jealous of Hopkins for a number of other reasons in terms of their legacy and their academic strength. No reputable medical or surgical programs treated transgender patients in the United States. So after Money's program was shut down, you could not find any place in academic medical centers or university centers that dealt with this. Harry Benjamin Society at that time had an underground network of providers in the United States. This was pre-internet, so that these individuals would write the Harry Benjamin Society and they would get a list of surgeons and physicians who were willing to treat the adults. This was adults only at the time. And those people were scattered all over the United States in small towns where they provided the surgeries or the medical treatments. The European landscape was much more open. From 1950 to the present time, medical and surgical treatment and counseling adults occurred in Denmark, Sweden, Belgium, and the Netherlands. Medical and surgical treatment for children appeared in the Netherlands around 2000. The Canadian landscape from 1980 to the present, Dr. Kenneth Zucker, a clinical psychologist, established a gender identity disorder clinic at the Center for Addiction Medicine in Toronto. And in his tenure there of over 30 years, he treated 560 patients, and he chronicled through counseling the achievements and published that. He developed standards of care with in-depth psychological evaluation of the patients and, most importantly, their families. 90% of his patients, biological males, and 80% of his patients who were biological females, resolved their gender incongruence with what's called the watch and wait. It really was not watching and waiting at all. It was very aggressive, continuous psychotherapy. The protocol, and as they passed through uninterrupted puberty, and this was alluded to before by Roger. Zucker was widely published in peer-reviewed literature, was considered the world's expert on gender identity disorder. He was responsible for including the category of GID in the Diagnostic and Statistic Manual of the American Psychiatric Association in versions 3 and 4. So, here we are with a tale of two different pathways to treat transgender individuals. We've got Kenneth Zucker's very well-established method, and then the European model, which is essentially crept into the United States. Let's talk about watch and wait and gender affirmation treatment. Watch and wait is based on biologic sex. It is the basis. It's very easy to do a scientific analysis. It doesn't require anybody's opinion. You are either biologically male or biologically female. Now, gender affirmation treatment is based on the theory that gender is biologically determined. It's innate. With watch and wait, it's now referred to as conversion therapy by trans activists, but it doesn't convert anything. It maintains biologic sex. So you're not converting anything to anything else. You are recognizing biologic sex and honoring that and getting that to be the basis where you move forward. It is anything but passive. It involves extensive initial evaluation of the patient and the family and the social environment, so it's both at home and at school. The adverse childhood events are frequently found, and they say that perhaps as a comorbidity, 70% of trans patients experience either depression, anxiety, or some other mental health issue. In truth, it's the depression and anxiety which are present in 100% of these patients, and transgender essentially is an escape route from the misery. It's viewed that way. But these adverse childhood events can be something as simple as frequent moves. In military families in the United States, that often move to preserve the career of the father who's on active duty or the mother. They'll move every 12 months to 2 or 3 years. And this becomes the program of the family where they uproot. The kids have to leave schools, leave friends, leave familiar places, and implant someplace else, reestablish friendships, and it's a very traumatic experience for some. it's traumatic enough that this kind of thing can affect a child's life with depression and anxiety and bring them to transgender as an option out. Death of a parent, obviously a more traumatic event that seems sort of inherent. Death of a sibling, death of a good friend, death of a grandparent, sexual abuse of a child by somebody outside the family or within. All those things are adverse child events that essentially trigger the anxiety and depression, and then the symptom of transgenderism comes to the top. This therapy involves intense, persistent counseling for the patient by a compassionate, caring mental health provider. Somebody with empathy, somebody who respects the patient, somebody who cherishes their client and looks after them, and in that way helps heal them by going into the dark basement where it's scary, musty, smelly, and evil, and cleans up the mess. No special expertise is needed by a mental health practitioner to treat a transgender patient that comes to the office. It's an illusion that anybody who is describing themselves as transgender, who presents that way, needs to go to a psychologist who is a transgender expert. Transgender expert is code for affirmation only, no other way out. Okay? So many of the mental health practitioners I deal with, when I talk to them, they say, I have no training in this. And I said, you don't know about anxiety and depression and you can't recognize it and counsel? Well, of course I can. Well, that's what the problem is. You need to, that's where this problem lies in it. That's where your area of expertise suits you well. The goal is to elucidate the undercurrent mental health morbidity and help the patient return to a state of positive mental health so they do not need to use gender discordance as an escape route. Gender affirmation therapy, on the other hand, there's psychological and medical side of it. Although recognizing biologic sex converts the social identity and physical appearance to that of the opposite sex. So banning conversion therapy should apply here. But taking charge of the words means that you can call leaving biologic sex intact conversion, and this conversion you can say is affirmation. It's crazy, but that's how it's presented. Ideally, this involves initial psychological assessment of the patient to rule out dissociative disorders, provide psychological counseling of the parents to accept their child's incongruent gender. So basically, the recommendation is make sure that this patient does not have schizophrenia, okay? And if they're not absolutely wildly crazy, then proceed appropriately. Affirm this child's sort of delusional belief that they are the opposite sex, and then spend all of your time counseling the family to accept this. Now, as it was alluded to, childhood adverse events which set up this whole issue involve, very commonly, the parents, who are absolutely ridden with guilt about their role in where their child is going to be and how they're behaving. And so they are very willing to accept counseling that says, let this go this direction. Okay? It promotes social affirmation of incongruent gender at home, school, and society at large. This is the activism we're all talking about, where the regulations in school systems and school boards and laws forbidding parents to call their child by their biologic, the appropriate pronouns, or otherwise be thrown in jail for child abuse. All of this is promoted in order to make the world essentially change to fit the delusion of the child. It interrupts puberty at the very first signs of pubertal change to allow the patient a period of time without any changes, hormonal changes, that would have been induced by their native pubertal hormones. Now, this is a theory again. This is not based on any science. They are actually doing ongoing clinical research. The longest trial period is 5 years to see whether or not these children are happy if they've had their puberty blocked. Well, this is a circumstance where puberty is not a disease. It's a process whereby the immature body changes into a reproductive body. It involves physical changes. It involves mental health and brain function changes. It's a very important physiologic change. There are some really painful parts of puberty that we've all been through. Acne, horrible acne, scarring acne is part of puberty. Would we treat that puberty by blocking puberty so that it wouldn't happen? Absolutely not. You treat the skin disorder and its reaction to those pubertal hormones. You don't cut the hormones off because the hormones are very important for so many physiologic functions. So why would we want to do that for this particular case? Well, if you block the puberty hormones, the male voice will not deepen. Okay? The hair on the face will not coarsen and thicken. So you can prevent some of the things that are hard to undo when you're trying to medically and surgically transition the adult patient to appear like the opposite sex. If you don't let these things happen, theoretically, then you don't have to worry about changing them or modifying them in these adults. And it gives this child supposedly a time to rest and consider, while they're maturing emotionally, whether or not they really want to go forward with this. The problem with this is that 100% of the kids that are put on puberty blockers go on to cross-sex hormones. There's no turning back. This is a gateway that ends up pushing these kids down a pathway from which they have a lot of trouble escaping. They introduce cross-sex hormones to bring about physical changes normally associated with the opposite sex. Now this is just kind of a cute slide because when you think injecting cattle with hormones is evil, but injecting kids with hormones just to change their gender is just fine. It's a very poignant way to look at how crazy it's become in terms of world political correctness. Gender-affirming options on the surgical side are in biologic males are removal of the penis. If the penis has been fully developed by puberty, then the penile skin is saved to line this soon-to-be-created vaginal orifice. If you block puberty, and the penis never gets to enlarge, which is what happened in the case of the famous American transgender kid, Jazz, they can't use the penile skin to create a vaginal orifice. So for Jazz, the vaginal orifice was created by using intestine, and it did not work. It ruptured. It has caused enormous amounts of physical morbidity and surgical morbidity, and it has no biologic function. You take out the testicles. You create a perineal cavity or the pseudo-vagina. In the biologic females, you take off both breasts, and you take out the uterus, the fallopian tubes, and the ovaries, and the vagina. And then you do what's called a phalloplasty. Now, this is from the movie Christmas Vacation. I'm not sure if you all are familiar with that. It's one of the series of Harvard Lampoon movies, and the crazy cousin or brother of the main character drives up in the driveway with this absolutely abysmal recreational vehicle that is torn and tattered and rusted, and he looks at his cousin and he says, "Clark, ain't she a beaut?" Okay, well, just look at this. This is taking the muscle from the forearm of the female patient and creating with skin from the hip and the buttocks an appearance of a penis. This structure has absolutely no anatomic function. You can pass the urine from what was the vagina area out through the opening. Not very well controlled. It has no erectile capability. It has no sensation. It is a costume piece. Okay? Plastic surgery programs in the United States and around the world are developing technologies to create look-alike pieces, body pieces, again, that have no function. And they're planting these on the perineal areas of women so that they can appear and stand and urinate, or at least stand naked and look like they have a penis. This is what, after it was all done, you can see the forearm of this patient where the muscle used to be, scarred, and then this is just a piece of tissue hanging from the perineum in that former biologic female. So let's look at the validation of success, okay, in the watch and wait side. I already alluded to Kenneth Sucker's work, but worldwide, including all through Europe, 98% of biologic males will realign their gender identity to their biologic sex by the time they have completed uninterrupted puberty. 50% of these males will end up with same-sex attraction. 80% of biologic females will realign their gender identity to their biologic sex by the time they have completed puberty, and most will identify as lesbian at some point in time during their life. Validation of successive outcomes through affirmation are initial euphoria. As when one of the patients said, I have gender euphoria. Isn't that a clever word? She found it on the internet and she really loved it because it sort of made her feel like she had made the right decision by getting testosterone injections. There was a Seattle study in children from their transgender clinic there that had 1 year of data where they asked the patients about their general level of success and happiness after living a year as being socially transitioned to the opposite sex identity. The study was done with people who volunteered to complete the study, not 100% of the patients in their clinic, but those whose parents rose their hand and said, oh, I'd love to be part of this study. Okay, so we have a selection bias up front. And then guess who they used to evaluate their children's happiness? The parents. They published this, and it was hailed as a landmark work in medical literature in the journal Pediatrics that affirmed that transgender affirmation is very successful, at least at a year's journey. And of course, it's a useless study. If it had ever been critiqued, like most medical literature, it wouldn't have even made it past to the first review and pass. Currently in the United States, we know from the European experience that overall satisfaction living the transgendered transition life in adults, that happiness begins to fall off dramatically after 10 years. It's not that they get to 10 years and all of a sudden wake up unhappy, but by that time they're declaring a significant number of these people wish and regret that they had not done what they had done. The National Institutes of Health Children's Study will gather data, and it's specifically a 5-year study. Well, if you already know that you can't get a valid answer until after 10 years of experience, why would you design a study that stops at 5? Well, you would design that study because it will prove what you want to prove in the beginning. So this is a study which has 1 more year to go in the United States. It involves 400 children from 4 academic university centers, all of whom are run by trans activists. So the study is designed, and outside of the funding, one of the study centers in Los Angeles is deviated from the protocol and used the funding to do mastectomies in girls as young as 13. That's what U.S. federal health tax dollars are being used for research in the United States. It is outside the bounds of the approved protocol, and yet it's happening and it's being celebrated. I will tell you that once this study completes, I can't imagine that within about a month it would be published, because they've already written everything they want to write, and they're going to put it out, and it will be praised as the landmark study justifying this kind of treatment for children in the future. A recent Dutch study about regret stops its data gathering at 9 years, and it's again a selection bias. It was recruited from patients that were in their clinics. It's less than 40% of the transgender treated patients overall in that country. What we do know from a study in Sweden, and in Sweden, like many of the Scandinavian countries, they have medical data on you from the day you were born until the day you die. Whether or not you want them to have the data in that socialized medicine system, they're meticulously looking after all 5 million people in their population and categorizing every aspect of their medical life and saving the data and analyzing it. So they did a study of the transgendered patients in Sweden, which is a country that many years ago, 20, 30 years ago, embraced transgender as a very valid way, biologically, medically, and socially, to live a life. So the society is very accepting of transgender patients. There's not a bias against them in society compared to many other places in the world. And of these patients who went through their lives and lived in 20 to 30 years into their transgendered health circumstances with medical and surgical treatment, there was a 19-fold increase in suicide compared to the general Swedish population, which is not a happy population compared to some other countries. So here we have documented evidence. This study is trashed by the trans activists because they say there is no control group. They didn't take people in Sweden who went through the counseling that Kenneth Zucker did in Canada and treat them and compare them as to whether or not they had a better suicide avoidance outcome than these patients did. There was no need for that. Okay? This is just hard data, and it's being castigated and rejected. The authors of that study themselves were put under so much social pressure by WPATH that they retracted their article and said they don't support it anymore. Yeah. Recent reviews of No Regret are flawed by poor quality data gathering. Now, there was an old joke back in the days when HIV sort of blossomed in the world, is the hardest part about telling your parents that you're HIV positive is that you're Haitian. And that was sort of an escape route from saying, I got HIV because I'm from Haiti, because that population seemed to be more at risk, or I used IV drugs. So the best part about being transgender is you don't have to tell your parents that you're gay. This is on the left you see the National Geographic magazine cover, which was published, Gender Revolution. And that is actually what we're calling the myth. And then someone did a very clever takeoff on that and called this gay eugenics, because you are taking the vulnerable child, kind of like Mike talked about this morning, who might consider themselves as leaning toward becoming gay or identifying themselves as gay. And the better way out is a medically valid diagnosis of transgenderism. You don't have to be gay anymore. You can go ahead and have the surgeries and the medicine, and you're revered in society if you do that. So in the United States, the transgender, as I said, the transgenderism was buried, and it was sort of, you went to the Harry Benjamin Society to find your support. Dr. Norman Spack is a pediatric endocrinologist in Boston, and he decided he wanted to spend some time in the Netherlands to visit their transgender clinics, where they had been treating the children now for over 6 years with hormones and surgery. So he returned to Boston after that, and in 2007 opened up our country's first official transgender clinic. One clinic in the United States in 2007. In 2009, the American Endocrine Society guidelines were published. Dr. Spack and his other colleagues from WPATH formed a working committee to import the WPATH standards of care and create the Endocrine Society clinical guidelines. Now, standards of care are used in legal terms. There are 8 members of the committee on this first, and most of them were WPATH members. Notably absent from this committee were the 2 primary leaders in the world on transgender health, Paul McHugh, the chairman of psychiatry at Johns Hopkins, and Kenneth Zucker from Toronto. Kenneth Zucker, who had been essentially the father of gender identity disorder as a disorder, psychological disorder. And he was not invited to this committee. So we have a bunch of people with an agenda from WPATH and no disagreeers on this committee. The authors are an adult endocrinologist from the United States, a general psychologist, probably I think the only mental health practitioner here on this committee from the Netherlands, a pediatrician, an endocrinologist, not a psychologist, from the Netherlands, an adult endocrinologist from the Netherlands, a pediatric endocrinologist from the United States. The reason these gentlemen's names are in yellow is because both of these individuals studied at Hopkins while John Money was on the faculty. So he highly motivated them to their viewpoints. Norman Spack, who we've already mentioned, is a pediatric endocrinologist in the United States, and an adult endocrinologist, Vin Tankrecia, from my hometown, Atlanta, on the faculty of Emory University. Vin was a bone metabolism specialist in his training, and he happened to get on the faculty at Boston out of his fellowship, and they needed somebody to do the adult transgender clinic, and he was the junior faculty member. So guess what he was assigned? And that's how he got into the transgender business. He had never had any formal training at all in terms of that, because no such formal training really existed. And then Victor Montori, an adult endocrinologist in the U.S. So the purpose here is that this is the United States Professional Endocrine Society, and there are 3 people from the Netherlands and 5 from the United States. It is making recommendations about treatment of children specifically, and look how many pediatric specialists there are. We've got 2 pediatric endocrinologists and a pediatrician. So the majority of these people have not anything to do in terms of training or experience with pediatric endocrinology, and yet they made these guidelines which essentially dictate what should be the standard of care for pediatric endocrinologists to use. 2000 guidelines, the scientific basis, 22 guidelines in total, 3 are based on moderate amount of evidence, scientifically published evidence, 3 out of the 22. The concern of these 3 was that we needed to do clinical research on the effects of puberty blockers and cross-sex hormones and their possible detrimental health results as a result of using these medications. That was the scientific basis they spoke of. Okay? Concern that there might be harm. Okay? Not there was unquestionable benefit. It's concern there might be harm. That's where the science is involved. 19, the remaining 19 were based on absolutely no scientific evidence or very little scientific evidence. Recommendations for trained transgender specialists, recommendations for timing of medical or surgical interventions. So these guidelines were knowingly published without scientific basis for the majority of what they recommend. And yet they were accepted. And that was in 2009. The incidence of transgenderism in the world's population in biologically female males has risen from 6 per 100,000 males to 3 out of 100, or perhaps in a California high school survey intimated that perhaps 27 out of 100 children had problems with gender incongruence or confusion. Just look at this since the guidelines came out. The ratio of males to females was 2 to 1 in the days of yore, but that has reversed, so that the predominance now is females wishing to trans to male identity. Now, you say, how could this possibly happen? Well, the guidelines are there, but this is an interesting graph out of the Journal of Human Sexuality. There we go. This is the ratio of males to females, male being the darker line, over all these years from the late 1976 onward, and the incidence of transgender as a medical diagnosis. Here is the onset of Facebook, here is the onset of Tumblr, and here is the onset of Instagram, and you can see, and this is just an association, not a cause. But isn't it interesting that with the advent of internet invading the lives of kids, that the incidence of transgenderism goes up and up and up, and the ratio flips from 2 to 1 male to female to 2 to 1 female to male. So clearly social media is in the mix in terms of how this becomes an epidemic. So the consequences of publication of these guidelines is also the ratio of males to females, and the number of transgender clinics has gone from 1 in Boston to 45 active academic center transgender clinics in the United States to the present day. And just look at that ratio. And where were these kids before? Were they hidden by society and hate and bigotry, and now they're feeling like they can come out from under the rock and into the sunshine and live the lives? No, it's actually a cult phenomenon. U.S. News and World Report is a magazine published in the United States which rates hospitals across the country and healthcare systems by the quality of their care.
Wow.
They have, under the endocrine guidelines, you get greater score points if you have a transgender clinic in your hospital. So the healthcare system in Atlanta that sent in their data is under the umbrella of what's called Children's Healthcare of Atlanta. It involves Emory University, hospital and the large clinical hospital, Scottish Rite in Atlanta, and they fought and fought and fought to make sure that their numbers looked better this year than last. And we were just announced that we rose from the 44th best endocrine program for children in the country to the 36th best in endocrinology. And boy, aren't we proud. The answer is no. The American Medical Association, the American Family Practice Association, and the American Academy of Pediatrics endorsed the Endocrine Society guidelines, and then went a bit further. The Pediatric Endocrine Society in the United States, which is just pediatric endocrinologists, published their guidelines in 2016. They essentially rubber stamped the Endocrine Society guidelines, but they added emphasis on providing regulations that would mandate insurance coverage for surgeries and medical treatments. Puberty blockers in the United States cost per year $30,000. Testosterone and estrogen are dirt cheap by comparison, so the cross-sex hormones, parents could almost pay out of pocket with a credit card and not feel like they've done anything other than maybe get a fancy pair of running shoes. But clearly $30,000 out of pocket is quite an expense for these families, and they are suing healthcare systems to provide them coverage, and winning. The 2017 guidelines from the Endocrine Society were a second version of the first, same lack of science. They loosened the age recommendations of these guidelines, whereas before they said no surgery until after age of consent of 18 in the United States. They suggested maybe surgery should be age 16 or so. And they also recommended that puberty blockers could be started earlier and cross-sex hormones started earlier. They added one additional guideline, and that was they needed to explain the inevitability of infertility that this would offer, so that these patients could cryopreserve their germ cell lines before they took their testicles off or had their ovaries cut out or before they went on puberty blockers. So they were given that option so that they could someday use their germ cell lines and have a child and have that commodity, as it's called. So the guidelines, and these are the same people that were on the second committee that were on the first. We added in a pediatric endocrinologist from the Netherlands, an epidemiologist from the United States. There's a good choice for a transgender. And then another pediatric endocrinologist who is an openly gay agenda person who I've known since he was a fellow, a very fine individual, but clearly agenda-driven in creating his clinic. And then Joshua Safer, who's an adult endocrinologist from Boston, who actually trained Vin Tankricha in the fellowship years. And he advocates that children be started on cross-sex hormones as soon as someone brings up the question. He said it's the job of the endocrine community in the United States to affirm, affirm, affirm. And then lastly, another adult endocrinologist from the Netherlands. So it's a bigger committee. Again, if you look at the mix, 6 people from the U.S. and 4 from the Netherlands, 2 ped endos, 3 adult endos, and an epidemiologist, 1 ped endo, 2. And so this is a committee, again, that refined the guidelines. Not to be outdone, the American Academy of Pediatrics in the United States developed their guidelines and published them last September. Openly, proudly, and staunchly say psychological evaluation of the child is a waste of time. It should be avoided. It is actually unethical. That's a statement in their guidelines. Now, how far off base can you possibly be? This is an organization of 66,000 pediatricians in the United States. A very large number for a specialty organization. And they are so politically motivated in their guidelines. There is the science that this person used to publish the guidelines was scoured. The references were scoured, and over half of them had nothing to do with what they claimed they supported in the position paper. As a matter of fact, some of them actually refuted the guidelines that were recommended. There was a clinical psychologist, a gay activist, who took these guidelines apart and said this is the most shameful excuse for a set of guidelines published by a prestigious organization. And it's incredible that this kind of stuff happens, but it is lauded and referred to as the standard of care. So, That's the Academy guidelines. It was written by one person. Okay, this is one person writing the guidelines. 66,000 members of the American Academy of Pediatrics, and 31 people had input for writing and approving these guidelines. That is a tiny fraction. That's how this happens. Just the activists come into an organization, hoodwink it, get their interests met and published, and then it looks to the world as if 66,000 pediatricians in the United States are in favor of this. That's what it looks like. So the landscape in the United States today, the critics of this concept of affirmation therapy are stifled. They can't publish anywhere. On the table back there is Paul McHugh and Lawrence Mayer's paper in the New Scientist, or the Atlantis, the New Atlantis. That New Atlantis is not a major medical journal in the United States, but that article is so amazingly rich with scientific background. And it would normally, if it weren't for the subject of sexuality, it would be published in the New England Journal of Medicine, or the Journal of the American Medical Association, or the British Medical Journal. Okay, but they would not accept publication of this. So Dr. McHugh, found a journal that would publish it, and immediately was castigated as a minor, useless journal written by right-wing Christian fanatics, written off. The people who are in academia fear the repercussions, and they hide in the dark, because if they open their mouth and state their case, they will be removed from their positions, and their livelihood will be gone. The head of the plastic surgery department in Columbus, Ohio State University, resigned in April of this year because of pressure by the department head at Ohio State that he would not, this plastic surgeon would not allow training of surgeries in his plastic surgery division. And as long as he was the chair, it would not happen. And the department head above him said, well, perhaps it's time that you leave. And so he did. He left a career during which he provided expertise and developed surgeries for women who had post-cancer treatment needs, from breast reconstruction and vaginal reconstruction, etc., from the surgeries on their genital structures from cancer. He was the world's leader and developed these things, and he was sent hacking because he would not kowtow to the trans activists. And so he's now started in a private practice in Denver, Colorado, launched onto a new career in his late 50s, and closed that chapter of his life, all because of repercussions from stating his case. Major continuing medical education meetings in the United States will not accept contrary opinions. I have offered to either speak myself or provide experts in the field who share my opinion at the American Association of Clinical Endocrinologists annual meetings, 2 separate occasions, and I have been turned down. So my presentations in the United States are small interest groups, regional endocrine meetings, the Christian Medical and Dental Association meeting, their national meeting this year in Ridgecrest, North Carolina. And I went to Australia last summer and spoke in 5 cities in Australia on behalf of the Australian Family Association on this issue. So that's where we get to speak, is people in places like this, venues here last fall at the launch of the IFTCC here in London, in this very building upstairs. I had the privilege to speak. And went to Budapest for the 3rd annual meeting of the IFTCC at the end of October last year. But we have, as we are here, we're sort of protected. The audience is limited to people who want to learn and sort of are prone to listen and not disrupt. While I was speaking in Australia in Melbourne, I had the honor of having embedded protesters stand up and start screaming at me from the audience. They were removed by security. They had implanted 3 waves of these people, and then they encircled the building with megaphones and ran sirens and screeched and slogans at us for the entirety of the rest of the presentation. So it's not that we are stirring the pot. We know that we're hitting a nerve. That's not our job. What we really want to do is bring things to light. As I've said over and over again, a dialogue is what we want, not a diatribe. And so that's our purpose. Medical schools are developing transgender curriculum. They have to make it up out of nothing because no such curriculum that they can find based on science exists. And research, as I said, is funded by the National Institutes of Health for $5 million to cut off girls' breasts. So there are 75 patients in the 4 centers, affirmation only, no control group. Here again, this is a place where you could use a control group. This is a scientifically valid study. Good science is based on putting 2 patient populations through to either prove or disprove your hypothesis. And with one, you treat one way, and the other, randomized, not selected. You treat the other group, and you look at the outcomes down the road. An ideal study then would be a multi-center study where patients were recruited and sent to the counseling arm only, which is watch and wait, and others who went through affirmation socially and medically, and hopefully not surgically before the age of 18 and consent, and look at the outcomes of those individuals in terms of their mental morbidities going in and the persistence of their beliefs. Acceptable standard in clinical research is that you should have informed consent. You cannot get informed consent in the United States from someone who is younger than 18 years of age. You can get assent from children aged 7 to 17, but the parents provide the informed consent for the interventions. Diagnosis must be established by a measurable criteria. Well, what is the measurable criteria for transgender? It's the opinion of a child. Now, the mantra of the transgender activists is that, how do you know a child is transgender? Well, they're insistent, consistent, and persistent. Doesn't that roll off the tongue like poetry? How many have raised toddlers in this room? Okay, we're talking about insistent, persistent, consistent.
Oh, they're very good at that.
Okay, and that's how they try to rule the world, and that's how we corral them in, and hopefully don't beat the heck out of them and raise them as happy children and functional adults. So that mantra, that's the test. Okay, that's the diagnostic test, based on the opinion of a child. There is no biological marker that you can use. You also need to have a balanced approach in your clinical research. That is to say, you have to look at the benefits versus the risks of what you're recommending. And then you have to have a randomized control group. And then you also have to have what's called an institutional review board, or an IRB. This is a group of individuals that has absolutely no relationship in any possible way with the researchers. They are an individual group of scientists who critically look at informed consent and look at the balance and make sure that all of these things are part of the protocol. And that IRB governs what can happen to the patients. This is part of the Nuremberg guidelines set up after the Holocaust and the experimentation on human beings there. There's a safety committee, even yet another independent group of people that looks at the data at critical intervals, usually 6 months if it's a number of year study, to look at the safety signals to say what happened. Were there any adverse events or serious adverse events that involve losing the life of the patient, even if it's not directly related to the study drug or the arm of the study. Every one of those things is looked at, and the studies can be stopped in their tracks within 24 hours if there is an adverse outcome. Okay, where is the safety committee in the IRB in this NIH study in the United States? They're nowhere to be found. We try to find the informed consent documents through the Freedom of Information Act, and no one will give them to us. What's wrong with the current state of affairs in transgender care? There's no diagnostic test, no biologic basis. There's the arrogance of the transgender activists who refer to anybody contrary as transphobic, bigots, and haters. No dialogue is allowed. There was a survey by the Pediatric Endocrine Society this year, sent to all of its membership, about their understanding of transgender medicine. There was no place in there where you could put a contrary opinion. It was all, do you have this that we think is important? Yes or no. Do you do this? We think is important. Yes or no. There was no place for commentary, and all the answers basically just affirmed what they firmly believe is that only smart people understand, and that's that gender affirmation therapy is the way to go and should be promoted. They misrepresent the data. A classic example is the 41% suicide rate of transgender individuals who are not allowed to have affirmation therapy. This is the mantra of all the stuff that passes through school boards and through houses of legislation in the states, the United States, to combat the idea that these children should possibly not be affirmed but should have counseling. That is absolutely bogus data. The 41% is actually the number of transgender adults who were surveyed. There were some 6,000 of them, who said that at some point in time in their life, they had hurt themselves. You take out cutting behaviors and self-mutilation, and that essentially cuts that number down to half in terms of those that attempt, actually do something to themselves attempting to kill themselves. They don't succeed. The actual number of suicides completed is vastly smaller, 2 to 3%. Still tragic, okay? But when you tell a state legislator that 41% of the patients will kill themselves unless you allow them to be transed over to the it pulls at their heartstrings, and they're thinking, oh my God, this is terrible. We can't let this happen. The American U.S. Council of Catholic Bishops relied on that data to put together a policy until they were educated by Michelle Pertella, our American College of Pediatricians, now executive director, and she explained to them the fallacy of this data, and their jaws dropped. They said they had absolutely no idea, and they're going to hold fast to a much more appropriate kind of recommendation as a result of that information. Transgender centers themselves are not adhering to the Endocrine Society guidelines. They're doing things way out of whack. They're putting hormones in and blocking puberty earlier and earlier. The Los Angeles Transgender Clinic suggests blocking puberty at age 8 or 9. So what's the trajectory at present? Well, we are medicalizing a psychological issue, clearly and simply. We created significant medical morbidities for a lifetime in these patients. Male patients who take estrogen have an incredibly high risk of breast cancer. Breast cancer avoidance occurs in the females by all the physiologic things that happen to the female body as it goes through puberty, through childbearing, and postpartum. That breast is protected from developing cancer by the natural process of procreation, childbearing, and lactation. And so when you take the hormone estrogen and give it to the male breast, it is just as vulnerable as the nulliparous woman who's had multiple abortions early in term, in terms of increased risk for breast cancer. So we're creating morbidities where none would have existed. We're putting these people on hormones they have to take for a lifetime to mock and appear to be the opposite sex. We are mutilating their genital structures. We are creating totally non-functional penises to tack on the front of the female's former vaginal area. We are opening a hole in the perineum of the male body and pretending that it's a functional vagina, which it isn't. And we're doing that for the lifetime of these patients. Psychological morbidity persists, as the studies have shown us. Multiple thousands of newly transgender pediatric patients are popping up in the United States because of this phenomenon. It's an internet-driven cult behavior, and increased numbers of adults who wish to detransition are showing up, Walt Heyer being one of the most vocal. I've had a number of times talked to him personally. Renee Jacks is another adult male who transitioned to female and is detransitioning back. Hashi Horvath, who's an epidemiologist at UC San Francisco, is an adult who lived 10 years as transitioned to a female. These people have had hormones and surgery, and yet they come back brave and strong to say, I'm an advocate for never doing this to yourself in the first place. Walt Heyer has about 700 people per year who approach him on the internet through his website to ask, how do I detransition back? This is gigantic. This is an epic failure. And the IRBs would look at these as stalking criteria instantly if they knew about them, but they're not taking this into account. Physicians and healthcare systems will inevitably face legal repercussions. These patients are so angry about what was done to them, and particularly if you think of the children growing up who, before the age of consent, had their parents sign for this and a plastic surgeon remove their breasts. I When they wake up 5 years later and say this was the wrong thing, do you think that they're going to leave that surgeon alone? Or their parents alone? Probably not. So everybody in the chain of command of medical treatment is going to be vulnerable to lawsuits. The dictum is, above all, do no harm. Or first, do no harm. This is the Hippocratic oath that we take when we accept our medical degrees. We should halt all the current affirmation efforts in transgender clinics and call for a review of all patient care provided to this date. The British Medical Journal just published an editorial essentially saying the same thing about the Tavistock Clinic. We must stop for the moment, quit what we're doing, take a critical look as to where the scientific basis is and what the possible harms are to these children. This needs to happen across the world, not just here in the United States. We need to halt the current NIH study and investigate how the study is being conducted, because we already know that there is fraud and abuse of federal healthcare government research dollars being practiced by the people who are running the study. We need to establish a balanced panel of pediatric, adult endocrinologists, mental health providers, and bioethicists, I mean, very important here, to critically review the world's literature and to build recommendations only on data that is strongly based on valid science. So that's the crux of what we need to do, and how we get there is with the help and enthusiasm and support of all of you who are like-minded. We need transparency so that transparents can see the whole story, or as I say, transparency. Thank you very much.